Hello and Assalamu alaikum. This is Dr. Sakhrin speaking, introducing a case of Quervain disease released with a longitudinal incision. This is the patient. She's a young patient, 25 years old, who had a pain that was not alleviated following steroid injection. We used the laziest longitudinal incision on the radial side of the hand. Longitudinal incision is preferred because it allows more delineation of the sensory branches of the superficial radial nerves and allows simple and more reliable release of the first compartment. In this case, we can see here the branch of the superficial radial nerve. In every case, I found at least one branch lying on the first dorsal compartment. So this is the first dorsal compartment. We see the sensory nerve and retracted, in this case volarly, in order to make a safe incision for the first compartment. We do the incision dorsally in order to allow a volar cuff, maybe to minimize the risk of volar subluxation, which is a problem that can follow the Quervain release. Following the opening of the compartment, we already see some tenosynovitis with a hypertrophied synovium that we excise. So this is a young lady which is not so classic for her to have a Quervain, even with some occupational risk factors. But in this case, she has a synovium, hypertrophied synovium. Maybe this could be the first sign of some kind of inflammatory disease, because she has robust synovitis, as we can see. So it's not only about releasing the first compartment, it's also about doing some synovectomy that will also release her pain that was not alleviated following the injection. Now, utilizing this longitudinal approach, we can use the scissors and open the dorsal compartment completely proximally and also distally. This is about 4 to 5 centimeter incision. Through this incision, we open distally the APL and the APB. We know that the APL has an accessory tendon which is volar, and we make sure that it's not interconnected or have fascial bands or tenosynovitis, and if there is some subcompartments, we open them also. Open the whole compartment and discern it to see that there is no subcompartments that needs to be opened, and we examine the tendons, see their function, see that they are free and there's no bands or fascial bands that need to be resected. We make sure that there is no synovitis left behind. In this case, this would be enough, but we found some adhesions between the tendon. We make sure that the compartment is fully released. So one concept about the longitudinal choice, I know that most of the surgeons do the horizontal transverse incision because of cosmetic causes, but I find it hard to find the nerve and keep it safe and do this more reliable release. Now we irrigate the wound profusely and then close it. I choose 4O Vicryl rapid suture. it dissolves on its own, and I use it in a continuous fashion. I think that choosing the longitudinal release could demonstrate better the compartment. We could see the synovium and resect it if needed, not only do the release. And I find it to be cosmesis-wise appealing, and I did not have any problem with it. I thank you that you watched this video. I hope that you learned something new. Thank you and Assalamu alaikum.